English student at the University of Utah, and I am also pre-med. That means that I plan on applying to medical school after I graduate next year. And I'm super excited today to be talking to you guys about COVID-19 and cancer patients alongside Dr. Osman.
Hi, everyone. My name is Afafa Osman. I'm a physician at the Huntsman Cancer Institute at the University of Utah. I'm an assistant professor and I'm a cancer doctor. So I see patients with hematologic malignancies, which just really means blood cancer. And I'm really excited to talk to you guys today about how COVID-19 has affected our patients with cancer, especially with blood cancers and the vaccine and treatments. And I'd like to thank you for attending and for giving us this opportunity to speak today.
Awesome. So to start off the presentation, we'll just be talking about a few health disparities in various ethnic communities. So firstly, I think it's important to mention that people who are African American, Latino, Alaska Native, and Indigenous tend to experience higher rates of hospitalizations that are related to COVID. And some factors that may increase rate of exposure include higher rates of exposure due to neighborhood and physical environment, crowded housing, such as when there are several families or multi-generations under one roof, occupation, such as healthcare, working in healthcare facilities, farms, factories, warehouses, food processing, and other things that put you in direct contact with other people. And not only that, there are also disparities relating to cancer, which you may not know. African Americans actually have the highest mortality rate and also the lowest survival for most cancers. Some factors that might contribute to this might be lack of cancer screenings among African Americans, as well as lack of accessibility to healthcare. And this picture actually illustrates the ways in which that African Americans actually have a higher mortality rate in some cancers. And so on the screen, we can see on the left-hand side that women, the higher rates of cancer tend to be regarding breast cancer and lung cancer. And on the other hand, men tend to also suffer more from lung cancer. And a cancer that is unique to men would be a prostate cancer. Another cancer that is more common in the US is colon and rectal cancer. Also, we thought it would be important to talk about a few possible complications of COVID-19 infection in some cancer patients. So to start off, more specifically, blood cancer and lung cancer are a few cancers that might increase complications if a cancer patient is infected with COVID. Not only that, older age is also a risk factor for more severe COVID. Additionally, cancer patients that live in areas of high transmission might potentially have to delay or actually even interrupt their cancer treatment. And lastly, COVID-19 infection in cancer patients can actually potentially lead to long-term health side effects. This is actually known as long COVID, which is when your COVID symptoms persist for multiple months. Now I will actually turn the attention to Dr. Osman, who will tell us a little bit about how we manage cancer patients who have COVID.
Yeah, so I actually wanted to also add that, cancer patients are receiving active therapy, so usually active chemotherapy, have a higher risk of complications from COVID-19. And then people who have comorbidities in general. So a lot of cancer patients are older, so they have other comorbidities like high blood pressure and like diabetes. So these are patients who are, again, at higher risk of complications of COVID-19, unfortunately. So in terms of the treatment is not very different from non-cancer patients, but we have to take in consideration that patients with cancer who develop COVID-19 have a higher risk of complications. So in the outpatient setting, for patients who have kind of mild to moderate symptoms, patients with cancer might have access to treatments that are not available to other people, including antiviral agents and monoclonal antibodies. So I encourage anyone with a cancer condition who develops COVID-19 to reach out to their physician as soon as possible, because they might have access to these medications that could decrease the risk of complications from COVID-19 infection And I would say reach out as soon as you have symptoms or you test positive, because the earlier that you get these medications, the higher chances that it's going to prevent you from getting worse and deteriorating. And then if a patient is hospitalized, with severe cases or with the moderate to severe cases, then usually the treatment is similar to other patients, but you have to keep in mind, the comorbidities and the medications that they're receiving for their cancer. And, these treatments include oxygenation, steroids, sometimes, again, antiviral agents and monoclonal antibodies as well.
So we will also be talking about the general vaccine recommendations for cancer patients. So in general, it is still recommended that COVID-19 vaccines are administered to a majority of cancer patients. And the most common types of vaccines are mRNA vaccines, which are Pfizer and Moderna. And,
so, yeah.
Oh, no, sorry, you can keep going.
Yeah, so I just kind of wanted to talk a little bit about the vaccine responses. So like Madika said, we do recommend vaccines, a COVID-19 vaccination in almost all of our cancer patients. And it just happens that people with cancer, especially people with cancers who are on active therapy, actually have a lower response to the vaccine than the general population because of a disordered immune system. So generally, the population, the general population, meaning people without cancer, respond better to the vaccine. And really, it's people with blood cancers who have the lowest immune response among cancer patients to the COVID-19 vaccination. But we still recommend these vaccines because they still offer some protection and they are still safe for most of our cancer patients. And I think the next slide, if we can go to the next slide, basically shows what the recommendations are for these immunocompromised cancer patients. So immunocompromised cancer patients really includes patients with blood cancers, because like I said, these are the least likely to respond to the vaccine, and then patients with cancer who are on active chemotherapy or therapeutics that decrease the immune system response. So the recommendations for the vaccine administration for these groups of patients is a little different from everyone else. So the primary series of the vaccine actually includes 3 doses instead of 2 doses for these patients. And the third dose in this scenario is what we call an additional dose. And it's different than the booster dose because an additional dose is given in cases when we think the vaccine is not producing enough responses. So when we think that the first and second doses are not producing enough responses, then the third or additional dose is given. So for immunocompromised cancer patients, we usually give 3 doses as a primary series. And then the booster dose kind of comes after, and the booster dose is given as a sort of a booster when we think that the immunity levels have waned or have decreased over time. So as you can see here, for the 2 most common vaccines that we have in the United States, which are what we call messenger RNA vaccines, so the Pfizer-BioNTech vaccine and the Moderna vaccine, the current schedule is on the screen. And this is really important information. I think every cancer patient should really know about this. So the first dose of Pfizer, the first dose of Pfizer, and then the second dose is 3 weeks after the first dose for Pfizer, and then the third additional dose is at least 4 weeks after the second dose. For Moderna, the second dose is given 4 weeks after the first dose, and the third dose, which we also call the additional dose, is given at least 4 weeks after the second dose. And then this booster dose, which is really a 4th dose in this vaccine series, is given at least 3 months after that third dose. And I'd encourage you to keep sort of following with the recommendations because they have changed in the last few months. So they might change again. So I would encourage you to keep an open communication with your physicians. The other thing we wanted to mention kind of really quickly is that in specific cancer patients, so these are the most immunocompromised, so the ones that have the least immunity from the vaccine. So usually these are blood cancer patients getting specific blood cancer therapies. In these specific groups, they might qualify for what we call pre-exposure prophylaxis using monoclonal antibodies. So this is, these monoclonal antibodies are basically what we call passive immunity, and they're specifically given right now for patients with specific types of cancer who are getting specific types of therapies who we think are not able to really get an immune response from the vaccine. So we think the vaccines are not working for these patients. So these monoclonal antibodies have been given for these patients. They're on an emergency use authorization from the FDA. So if you are a blood cancer patient, or if you are receiving very immunosuppressive therapy, ask your doctor about receiving this pre-exposure prophylaxis monoclonal antibody. So I think let's go to the next slide here. So this is actually just showing that really the patient with the blood cancers, and specifically a specific type of blood cancers that are called B-cell blood cancers. So things like multiple myeloma, things like lymphoma, and then specific therapies like rituximab and BTK inhibitors. So these are the patients that have the least kind of immune response to the vaccine. So they're not really benefiting as much from the vaccine as everyone else. They're still benefiting, but not all of them. This is just showing that when these specific groups of patients get a third dose, so that additional dose that we talked about, 55% of them actually start making antibodies, and we can detect antibodies. So the third dose, specifically in these populations of patients who are not really mounting, or who are not really getting a good immune response from 2 doses, is helping about 55% of them to mount a good antibody response, a detectable antibody response. So the third dose is really important for this group of patients. And I think the next slide is talking about sort of the side effects from the vaccine. So the vaccine has been pretty safe, and this is in blood cancer patients. As you can see, the side effects are really mild for these patients. And most patients get a sore arm basically, and then about 13% have no side effects whatsoever. So again, the vaccines are really safe in patients with blood cancers, and the side effects are pretty mild. So we can go on to the next slide.
Yeah, and lastly, we also wanted to discuss just a few effects of the pandemic on cancer screenings. So something that you may not have known is that there's actually a higher rate of cancer patients that are diagnosed in an emergency setting versus a non-emergency setting. And due to this, most of the diagnoses are actually end up being in later stage cancer, as they did not have the opportunity previously to be diagnosed earlier in their cancer. And another effect of this is that there may potentially be delays in treatments for patients that are recently diagnosed with cancers.
Yeah, and I think that this is a very important point to emphasize, because earlier, especially earlier in the pandemic, a lot of people were avoiding healthcare facilities, which is really, understandable, right? Because the healthcare facilities, were really highly impacted by the COVID-19 pandemic. But that led to a lot of people missing on their screening. And as you know, for a big number of cancers, the screening is important to catch them in early phases. Screening for colon cancer is one important one that actually affects African Americans disproportionately. Screening for breast cancer, cervical cancer screening, prostate cancer screening. These are all cancers that we know screening helps in detecting them early. So unfortunately, a lot of people missed out on their screening during the pandemic because, for various reasons, maybe they didn't want to present to the healthcare facility that had a lot of COVID patients, or maybe their visits were canceled, or maybe they had other obligations. They're taking care of sick family members. But that really kind of it led to a lot of people presenting with later stages of their cancers, and unfortunately it's harder to treat in a lot of cases at later stages. So that was a very big impact of the pandemic on cancer patients, unfortunately. And then some patients also ended up, getting COVID around their diagnosis time. And, a lot of the time we cannot start very heavy chemotherapy or chemotherapy that would suppress the immune system if a patient has COVID at the same time. So there have been delays in treatments, either in starting treatment for newly diagnosed cancers, and there have been delays in also administering treatment for patients who, get COVID while they're actively getting treatment for their cancer. So that's another way, how cancer or COVID-19 impacted our cancer patients.
And then here we just have another figure or image to illustrate the points that Dr. Osman made earlier. So there are three key effects or more dominant impacts that COVID has had on cancer patients and their access to healthcare. So firstly, like Dr. Osman mentioned, a lot of cancer patients have actually had their appointments missed, rescheduled, or even canceled, or they didn't show up. And that's a pretty significant portion of the cancer patient population. That's around 40% of those that have had some of their appointments shifted around. And then additionally, around 35% of cancer patients actually report that their doctors have switched to telehealth or telemedicine appointments. And Dr. Osman can probably speak to the double-edged sword that is telehealth.
Yeah, I think that one of the biggest effects of COVID-19 in the healthcare system is that there has been wide use of telehealth. And for those of you who do not know what telehealth means, it's basically seeing your physician through video, basically. This existed before the pandemic, but after the pandemic, there's been a wide sort of use of this technology. And the main reasons have been that, to reduce exposure risk, right? And I think, as Marika said, this is a kind of a double-edged sword, or it has pros and cons. And I think one of the pros of it is that it has enabled us to provide more care for patients who are in rural areas, for example, especially in a place like Utah, where a lot of patients are in rural areas that is hard for them to travel all the way to, a tertiary cancer center like where we're at right now. So I think that's one important thing about telehealth. And I really do think that telehealth is here to stay. But I think that another important thing to note about telehealth is that it can create disparities. And we all know that there are disparities in access to the internet in the United States that, affect people of certain ethnicities and of certain socioeconomics more than others, right? So in order to join a telehealth visit, you need access to the internet, and you most of the time need access to high-speed internet, and that we know that that's not available in a lot of places. And a lot of people who are African American don't have access to that, so that creates a disparity in that we have to consider really as we move forward with more use of telehealth. And then there's a lot of people who are still kind of technologically are not, up to date with telehealth. So, especially older people who do not use technology as much, people who don't have, devices that have these programs that can run telehealth. So I think telehealth is really a wonderful advance in medicine, and I think it's needed. I think it's here to stay. The pandemic has really kind of like opened up the door for telehealth. But I think at the same time that we have to be careful sort of going forward with telehealth to make sure that we're including all of our patients and it's reaching, all the people that it needs to reach. And I think, the next one is I'm too nervous to travel to my doctor's office. And that kind of goes back to the problem with screening, right? So, too many people are too nervous to come for their screening exam. And they think that maybe if I delay my screening for another year or two, nothing will happen. But, it could be that delaying the screening for a year or two makes a difference between finding the cancer in an early stage or a late stage. And then, we know that some people, have with how much just misinformation that's been around with COVID-19, some of this misinformation has also been carried around with cancer patients as well. So unfortunately, there's this sort of like problem that's arising now where misinformation about COVID is going hand in hand with misinformation about and cancer treatment as well. So a lot of patients, unfortunately, a good number of patients, unfortunately, have been victims to the misinformation that's been going around about medicine in general. And I think the other one on this chart that's really important to also talk about is the fact that some surgeries were canceled. And we've had that happen here in Utah, unfortunately, during the peak of the pandemic. Thankfully that's not the case anymore, but at some point even cancer surgeries were being canceled because of how hard was it, how much the hospitals were flooded with COVID-19 patients. So that definitely affected cancer patients. Yeah.
Okay, awesome. I personally just want to say that I'm really grateful that we have the chance to speak to you all today and just talk about some information about COVID and cancer patients.
Yeah, and I think I just want to say that, the cancer population is a population that was very severely impacted by this pandemic from the very first day that this pandemic started, and continues to be impacted by the pandemic. I think, as more people are getting vaccinated, as we're discovering or as we're learning more about how to treat this disease and more medications are available, monoclonal antibodies, antivirals, I think that the impact has been decreasing and things have been improving, but I think we're still this is still not over, especially for patients who are immunocompromised. And I think one of the things that I especially feel and sympathize with for my patients and for all cancer patients is, as things kind of go back to normal, and people are getting more and more vaccinated, we have this population of people who the vaccines are not, as functional, who are at higher risk or immunocompromised. And I encourage all of you to keep in mind, these cancer patients, when you're out there, just continuing to comply with all the guidelines from the CDC and from the healthcare agencies about masking, about the vaccines, because even if you're in a low risk group, there might be people around you and you might not know, who are in high risk groups, who are immunocompromised, who are still at risk of complications from this disease, whether these complications are infection or hospitalization or delay of their treatment or delay of their surgery, their cancer surgery. Some people get an infection and then they can't do their surgery and then they can't do their chemo. So I encourage everybody to just consider, your colleagues, your friends, people who, your neighbors who might have, cancer, who might be immunocompromised during this pandemic.